Well,
Yeah.
okay, super. Well, it's a pleasure to be with you virtually. I'm actually out here in Utah in Deer Valley with my family for a long planned break. So I appreciate the opportunity to take a couple minutes and speak to everybody. For a long time, I've been very interested in trying to develop technologies within neurosurgery, and that's covered the gamut from hydrocephalus to sports equipment. And about 6, 7 years ago, I got very interested in a technology called light field imaging, and VR was just coming about at that time. And it seemed like there was an interesting opportunity to leverage VR in the operating room. And so this spawned an enormous amount of work originally through the University of Washington and later at a company I'll talk about a bit called Proprio. So I'm faculty at the University of Washington, professor of neurosurgery there. I work principally at Seattle Children's, but I also do the spine work with my colleagues over there, Jen Bauer. Through the university, as I mentioned, had many opportunities to bring some technologies forward, and have always really looked at how do we address these clinical problems and apply new and emerging solutions. And so I'm going to talk a bit about sort of our view of where we think spine surgery is going to go. And the last talk alluded to a lot of the interesting things that are happening in this space. So my disclosure relates to a company, again, Proprio, that we formed a number of years ago, and I'll show some examples of the technology we're working on. So I always like to look back at some, leaders and quotes from them around innovation. And, Steve Jobs, obviously, we all look at him and go, what amazing things occurred over the course of his career. And, the innovators are the ones who are leaders. Everybody else is following. And if you've always done it the same way, it's probably wrong. And I think, in medicine and surgery in particular, we get very ingrained in the way that we think about things and the style of technologies that we adapt and use. Big epics or changes in the evolution of technology generally come slowly or adapted slowly. And part of my talk here is to get everybody encouraged that, hopefully these things can occur at a faster pace. And, we've all seen this quote that when we continue to do the same thing over and over again and expect different results, that's probably not the smartest or sane thing to think will occur. This quote from Jack Walsh makes a lot of sense to me. So, in the talks today, and often we're getting industry coming to us and saying, we've built this, we're innovating in this way for you. And I've always wanted to take the approach that the surgeons know what our pain points are, where we want to do something different, what the challenges are. And so a big part of what I've tried to do over my career is to encourage surgeons to actually come up with these ideas and move them forward, and not solely rely on industry to come to us with what they think is the next great innovation. So I'm going to talk a little bit today about sort of my thought process around innovation in spine surgery. And this is, for me, really moving beyond hardware. I think there's been amazing things done in the last couple decades around implants and hardware and various solutions that have certainly advanced the field. And we're starting to see now emerging technologies come in, like robotics that you just heard a bit about, and different ways of doing intraoperative imaging that are evolving. But the premise of this talk for me is that I think that my thesis and the thesis of the group that I'm working with at Proprio is really that innovation, not just in spine, but really in surgery in general, is going to require the digitization of the operating room. If you look at other areas where we've really taken and evolved technology, it's where we've gone away from anything that's analog, and the digital world allows a myriad of things to occur. So within spine, we're talking about significant improvements in navigation technologies and accuracy, really moving away from ground glass and microscopy to digital microscopy and visual technologies that will really, I think, evolve and change the way we work in the operating room. We've seen big data start to come into play on the medical side. The electronic medical record now is a wealth of information. People are starting to aggregate data and dig deeply into that. Same thing in genomics. But if you look around the operating room, there's very few ways to acquire large scale data that can be looked at either individually or in aggregate to understand what's happening during that surgery. And so as we look to apply all the catchphrases of, artificial intelligence and machine learning, those are all based on having these large data sets, which today generally don't exist at scale. One of the things that I think is a huge opportunity going forward is to provide clinical decision support to the surgeon. So I'll talk about this in a moment, this concept of a super surgeon, but really what makes you a great surgeon? It's certainly the skill at performing the operation, but it's your clinical decision-making during the case and the different steps during the case that really separates those who are experts in the field from others. But the idea is if you have a bunch of data and you can leverage that data and bring information to a surgeon while he's operating just at the right time, you can really provide very important decision-making tools in surgery. Telesurgery. So we're starting to see different companies coming out now that are putting cameras over the surgical field. These are generally standard cameras. And I had the experience a couple times recently of using MS Teams to proctor a colleague in Adelaide, Australia through a rhizotomy. Fundamentally life-changing experience for me. She had never done the case, and I sat in my office for 6 hours and walked her step by step through that. We've done that several times, both back and forth. Really amazing look at what the future holds for this. And then the world of robotics. I appreciate the comment in the last talk that current robots are really glorified drill guides, but you can certainly see the evolution that is coming forward as the robots become smarter. You have better navigation to control the robot and bring better information to it. We're certainly going to quickly evolve to the capabilities of the robot and eventually get to semi-autonomous and certainly downstream autonomous robots in some use cases. But all of that really requires that the OR become digital and that we be able to bring data sets to enable these technologies, but also capture that data to learn. So a large part of this for me has come from just looking around what's happened outside of the operating room. Our world has completely changed in the last 10 years. You don't go to a bank anymore. You text your friends, you socialize on Facebook or Twitter. The way people learn is completely changed. You have instant access to data and information. All of those things have happened outside of the operating room through computers, cell phone, internet of things, and various applications of robotics are starting to come into our life in different ways, whether it's vacuuming your floor or whether the car that you have is going to drive you home after a day in the operating room. But we always seem to be 20 years behind an operating room. And so a big thrust of this talk for me is to encourage everybody to look around at these incredible emerging technologies and see how they can fundamentally impact our ability to operate. So I talk about this super surgeon quite a bit when I give talks. And, when you look around what enables somebody to become a really good surgeon? Well, there's obviously innate ability. And we know that just like in astronauts, there's a bell curve to neurosurgeons, there's a bell curve to orthopedic surgeons, and you have colleagues and folks who've trained you, hopefully, that you think are just absolutely amazing. And then, people in your field who probably could do with a bit of improvement. So the question is, how do you make everybody a highly skilled surgeon? And along those lines, what does learning look like? I think that for certain, we're going to be having technologies coming forward where we're simulating before we go and operate on live patients. It's been happening in aviation. You don't get on an airplane now with somebody who just decided to fly you for the first time. They've done thousands of landings in a simulator. Data from the operating room will inform how we're doing this with VR, simulation, et cetera. I mentioned clinical decision support, and how do we augment that intellect, if you will, of that surgeon by aggregating and distilling data that can be brought into surgery in the moment that it's needed. And then surfacing knowledge. So, we're always very interested in outcomes, and, folks who are in the spine world to spend an immense amount of energy with registries and looking at techniques and implants and outcomes. And these are very hard, costly studies to do, and it's very hard to get large volumes of data. But if you're in the operating room and you can capture the data as you're going, being able to apply these different algorithms can surface knowledge that may not be visible to traditional methods of learning and study. And so as I've looked around, there's a world of things that are going on around us now that are fascinating. So technologies that are very germane to spine surgery in particular, computer vision, which I'll talk a bit about in a moment about what we've been doing. Extended reality is really this world of virtual reality and all the incarnations that is bred, whether that's mediated reality or other types. That is only going to be evolving and advancing, and how we operate and what headwear, for example, that we're using, these things are coming into the operating room, and they'll be there, I think, very soon. Edge computing is the ability to do computation on the devices in the operating room versus using the cloud. But 5G is going to have a huge impact in the operating room to be able to move large amounts of data with low latency. Computational healthcare is a terminology that folks are using, certainly out in Seattle and other places around the world, where this idea of, can you bring this enormous compute power to healthcare, and specifically, again, in surgery, what does this look like? How are you managing the robot? How are you planning the screws? How are you looking at the patient's preoperative anatomy against a database like Metacrea is doing, trying to obtain an optimized outcome? All of these things are going to be done through computational science, and the art of medicine has gone away in many places. It's still very predominant in spine surgery, but the art of surgery will eventually fade away, and we'll have much more robust and systematized ways of doing these cases to arrive ideally at a known outcome, and then robotics, as you've heard. So one of the things that's interesting around data is, what makes a skilled surgeon, and ultimately what makes for a good outcome. And there's so many variables that go into it. It's a very hard thing to understand, again, without acquiring the data in the OR. So we talk about, where do you train? What facility are you at? How many years of practice? What technology did you train in or out of the US? Do you practice in or out of the US? All these things go into this black box, which is the operating room. And the output is surgical performance and ultimately the outcome of the patient. And so that data is largely unknown at this point. So data really is going to be there to enhance human capability and the performance in medicine, but and specifically for this group in surgery. And that's going to incorporate a variety of different types of cameras and sensors that come into the operating room. This data is going to be captured, computed, and then output in various ways, whether that's aggregated data in the output from that, or maybe it's going to be how you're visualizing the case, whether this is real-time digital microscopy with navigation information overlaid on it. All of these things are coming. So again, first, digitize the entire operative event. So I'll show you a little bit about what we've been working on over the last 6 years or so. So in the company that we've formed, Proprio, that's going to be coming to market shortly, we're using light field technology, and this demonstrates the concept. So you're taking multiple cameras and looking down at a scene. You're capturing a very dense three-dimensional data set that occurs longitudinally over the case. And so you can do a myriad of different things with this type of technology, from navigation to microscopy to a whole host of other things. But the idea is that we're acquiring an immense amount of data that can then be parsed for different use cases. And so what you see on the right in the picture here is the system that we'll be bringing to market. This is one of the most highly powered computational devices that will ever see the inside of an operating room. I tend to call this operative computational science, and this is really an algorithmic, real-time, multimodality, multi-sensor array leveraging machine learning, computer vision, and robotics to be able to help inform the operation. We're taking our initial use case in spine, but this can be applied across really any area of surgery, including obviously cranial neurosurgery, but well beyond that. We will ingest scans initially with CTs, as you heard in the last case, go through and do auto segmentation. Is a fascinating area that's burgeoning of taking different types of imaging data sets and parsing them and looking at individual components that you can then break down for various applications within surgery. Again, surgical planning, how do you take and optimize the entry points and trajectories for those screws? We're using, again, light field imaging, so we're doing real-time continuous navigation, and the evolution of this technology will be that you won't have to have any markers or things bolted to the spine. That technology is already antiquated. And then we'll go through and be able to provide the guidance. This is an example of the CT that we took of this sawbones model, warping in three-dimensional space in real time back to the actual anatomy. And so you'll be able to take and move the anatomy, as was mentioned in the last lecture, but not have to re-image with a O-arm or 3D fluoro. You won't need to have multiple attachments on the spine. You'll be tracking the actual anatomy in real time and then warping it back to the image sets that you need, same as bone or tissues removed, et cetera. So there's going to be a complete, what I've termed frame shift in the technology that's coming into spine. It's a super exciting time for all of this stuff for us as surgeons in this space. Again, because it's digital, you can start to represent a variety of different things. So what are your trajectories? How wide is the pedicle? How long is the screw? These are things that are in the space now, but you can imagine a variety of other things that come out too. How do you integrate MR and CT and a bunch of other data at the same time? How are you providing guidance around how much bone you're drilling or alignment or a variety of different things? These are all enabled through digitization in the operating room. This is an example of me in a headset. This is an Israeli military headset with near eye resolution. And what you're looking at in this video is I'm looking at a rendered vertebral body with the navigation information applied. You can cut in, cut out of this as you move around. The headset is being tracked dynamically. So this is where the operating room is going. It's going to be real-time information that helps you manage the case. Things will be brought to your attention if you're about to do something wrong or harm the patient. And all of these things, again, are in our immediate future as surgeons. So one of the things that's interesting here too is just the amount of data. So our system alone will initially capture upwards of 50 gigabytes of data an hour. That's an immense amount of data. And so the question for us and others in the space is going to be, how do you manage this? How do you offload this data, process this data, bring the data back into a useful fashion? And just an interesting statistic here, 2.5 petabytes is the capacity of the human brain. And over the course of just 1 year with a single system, we'll acquire that amount of data. It's an immense amount of data. And if you think about a three-dimensional data set captured longitudinally over the case, and you do this hundreds of times across thousands of surgeons and thousands of operations, and you can apply compute against that, you're going to learn a lot, right? You're going to learn what techniques interoperatively are working, where are mistakes happening. You're probably going to understand who's a really good surgeon and who's an average surgeon. We're going to have to figure out how to deal with that type of stuff. So in my last couple of closing slides here, there's certainly innovation challenges for this digital world, but some opportunities too that are very real. So the cost of these systems, the last presentation by Stryker, that is not going to be a cheap robot. You're not going to get that robot for $50,000, right? So systems will want to lock you into these huge capital purchases. Well, I think there's opportunities as software becomes the driving factor for innovation, that you can reduce the cost of getting these cutting edge technologies and be able to apply them not just in the world leading quaternary care centers like where you guys are sitting today, but can we get these things out across the world, and do we bring the cost down enough that they can be very useful in surgery centers, for example. Adoption. So, I would argue at this moment that it's standard of care to navigate a case. Many of my colleagues would argue that at this point in time. So the adoption curve is just that. It's a bell curve. And hopefully these technologies will be picked up quickly, because I think it's only going to be to the betterment of our patients. Data security and how we manage data ownership. These are going to be huge amounts of data. The hospitals want to own it. The companies want to own it. Maybe the patients are going to want to own it. And we haven't quite figured out how to deal with that. And then data standards and interoperability. So I think one mistake for us as surgeons and as companies is going to be to try and keep all this data and hardware and software just completely closed down. And if you look out in the world outside of surgery, when systems have been open sourced and open platform, the rate of innovation has been exceptionally quick. And so I think there's ways that we should be thinking about this differently. And then certainly educating the FDA as these new technologies come, so that we're not spending years trying to get these things through into our patients. So I've mentioned the majority of this stuff already in the talk. I think data is going to drive many things in the preoperative setting. Simulation, training, being able to repeatedly do cases or repeatedly deal with a challenging complication before that ever happens on a patient. I think it's going to democratize the ability to learn, and you're seeing this already starting to occur. Textbooks will be totally different than they are today. Interoperatively, data is going to drive how we see the case, navigate the case, decision support, whether we're proctoring somebody remotely or sharing that data with our junior resident who's in the back row, but they can see the case just as well as we can. And certainly everything that happens in robotics is going to be driven by data. And the better the data, the better those robots will become over time. And then in the postoperative setting, it's this large aggregation of data. And what do we learn from that? How do we pull that data together, understand insights that are drawn from that, that can inform not only what we're doing in surgery, but improve and understand outcomes, and really extract those pearls of wisdom that I think we all garner both through training and over many years of practice. That N of one and that tribal knowledge should not evaporate when that person stops practicing. We should all be able to share in that knowledge. So I'll end with this. Innovation and my thesis, and certainly the thesis at Propria, is that we need to digitize the operating room. And that's going to allow us to progress development in spine surgery, I think similar to what this quote from Nikola Tesla is alluding to. That's very germane for what we're trying to do in spine surgery. So with that, I'll stop, and happy to take any questions. Thank you.
Thanks, Sam. That was a great talk. You really forward thinking with your development, and I'm looking forward to seeing where Proprio goes in the future. Are there any questions from the audience? Oh, here we go, Christoph.
Hey Sam, sorry, I was in the cadaver lab, so I just saw the last part of it. I mean, one question I have for you is, when we have more and more sophisticated systems like the ones that you're putting together, do you have to put a backup plan into place too? Let's say you have this, the robotic system operating in like the Middle East somewhere or whatever, and what is your backup? Because I mean, again, in healthcare, as you know, we all are held to N of one. Like all this 90% that we do in a hospital is because somebody did it in 76. There was one case, and that's why you have to fill out these 15 papers. So what is the preemptive sort of like solution for that?
Yeah, nice to see you, Christoph. Very weird being in another state saying hi to you. So yeah, it's a really great question. So, as we get more and more dependent on technology, I'm sure we're all hearing about colleagues who either know somebody or know of someone who's canceled a case because the navigation system's not available, right? And so we need to be able to have the systems available, but also be redundant in different ways. And so if we're becoming fully dependent upon these technologies going forward, just like in an airplane, there's multiple redundancies for every operating system. And that's not currently the case in these systems that are in the operating room. So as we become more and more dependent on these, we're going to have to integrate into them redundancies that allow for those systems to be performant, even if something fails. The one thing I would also comment on, and as a surgeon, I think, and certainly somebody like yourself, where we're training residents, the surgeon should always be able to perform the case, right? And so I hope that we don't evolve to a point where we're really just computer technicians and we're not surgeons. And so I think that's a really important point, that for me, technology, especially in the next 5 to 10 years in particular, is meant to augment our capabilities, but not replace us or our capabilities in the operating room. So I think it's going to be a couple of things. We need to make sure people are really well trained, and I think technology is going to allow that to happen in a way that really hasn't happened at scale before. So that we have really good surgeons that are out there, but also the technologies themselves, as we become more dependent on them, we have to make sure that they're highly reliable and that these failure points have significant redundancy so that we don't put the patient in harm's way if these things were to fail.